So thank you again for the kind invitation, and will be also, I will insist on inspiration in this case. We will discuss of this case. So I would like to present Thygeson superficial punctual keratitis and ask you and discuss with you or recognizing perhaps a new actor in inflammation in this disease. So Thygeson is a bilateral recurrent corneal epithelial keratopathy that affects the central of corneal opacity. You all know this clinical aspect. It presents bilaterally as numerous strictly epithelial oval shape, small, white and gray. All, as you can see on this slide. Clinically, it can be really a source of bad quality of life with recurrent attacks, eye irritation, foreign body sensation, mild pain, photophobia, tearing. You well know, I hope, the ocular discomfort that they have. The clinical course may last with children 2 months, as 41 years, so to be quickly or really long in the life with patient. And this entity has been described in childhood or classically more later. The average is 29 years. And classically, is predically a female gender. So, what's the physiopathology? Quickly, etiology, we don't know. Etiopathogenes remain unclear. Both viral and immunological mechanisms have been implicated as potential trigger. Some have described a significant association with HLA-DR3 and HLA-W3. But like we saw, there is an interesting element in this paper showing confocal aspect in Thygeson. What's really interests me, the highly refractive dots and aggregation of dendritic cells, so macrophage, in the basal cell layer of corneal epithelium. There are also aggregation in dendritic cells, as you can see, in the subepithelial nerve plexus of the cornea. So, this clinical aspect suggests this accumulation, aggregation of longer cells, suggests an immune response to an unknown incitating agents. So, based on this, classical, the heritage of the treatment of Thygeson, I hope that we do all the same, could be first artificial tears. Patients with mild symptoms and really quick and nicely managed with artificial tears. Corticosteroid, the use of steroids is classical and are significantly disabled by pain, photophobia, and reduced vision. So, classical treatment of this superficial keratitis of Thygeson. Sometimes we could have corticodependency or resistance. So cyclosporine can be used as alternative. Different concentration of efficacy have already been published. And sometimes tacrolimus, if you have cyclosporine resistance, could also be used in this pathology. And classically, as you can see, you treat the patient, all is better, and you hope you will not have some recurrence in the year or the weeks later. But sometimes it's more difficult. I will report 2 cases, a young woman of 45 years, 1 year of history of recurrent bilateral episode, described as burning sensation, decreased visual acuity with corticodependency. I was very proud of my formulation of topical cyclosporine 0.%. I tried. She didn't support it. Some week later, I tried my formulation of tacrolimus 0.02%. She didn't support during 3 weeks, so I was with no solution for the moment. As you can see, we have a classical aspect of the clinical epithelial grace dot. OCT confirmed the superficial aspect and condensation of cells and epithelial level. The second patient was 3 or 4 years history of recurrent bilateral episode with ocular irritation, photophobia, decreased visual acuity. She was working, she was really complicated for working in a bakery. She was corticodependent and the same. She didn't tolerate my topical cyclosporine for 3 weeks. I tried the same, tacrolimus. The first week it was better, and 1 month later, no more amelioration. So as the same clinical aspect, clinical necessity. So, what can we propose? And this is aspiration. I ask you, what can you do in this case? I hope you can help me. Nobody. You don't want to help me. What? Oui, Marc. I didn't understand.
Did you try hydrocortisone short term?
Yes.
It worked?
No. It means slowly amelioration after you. Normally you try to avoid some complications, so you stop and you have recurrency every time. So in the second case, I told for you it was 5 years of recurrency with different ophthalmologists.
In some mild case, you can use azithromycin, which has an anti-inflammatory effect. So this in some cases, and in some very refractory cases, I use contact lenses, soft contact lenses. So they are not symptomatic, but they have still the infiltrates.
So I won't say really high level. There is a problem in this little inflammation, ocular surface of tolerance, or some azithromycin drops. So they didn't support it. In one case, I tested. I didn't. I changed my strategy in the other. And the contact lens, both was unable. I tried because it's a classical. The next level should be PTK, no, but they didn't want to with contact lens. Even the second was worse. I tried because it should be a nice improvement in the clinical aspect and the quality of life, but she didn't want this solution. So, another idea?
Since you showed some infiltration of intraepithelial lymphocytes, liftigras might help because it prevents.
Yes, but in France, we don't have the lucky, it's not this problem. So, yes, a last suggestion, I will explain what I decided to do. The problem is that it could be recurrency, because the physiopathology is an inflammatory, so as you see, the recurrency are not always in the same place, so I didn't try this. So, what I tried to, for this patient, because I was really, first was a quality, a real bad quality of life. Yes, I did it. I tried the three levels. So, yes, I remember the implication in the confocal aspect of activation of macrophage. So I was thinking about what is pro-inflammatory in ocular surface, and we all know and we all forget, I think, the complement on ocular surface. So I realized that C3A and C5A, who are pro-inflammatory, they was matching the mechanism, the first thing we know about the physiopathology, but activating of macrophage was matching with the activity of C3A and C5A. So I was proposed to the girl to try off-label treatment with a drug that is 30 years on the market with no side effect. I tried to block the activation of complement with a blocker of C3 convertase. It's called NAGA. As you can see in this paper, NAGA is also powerful in high inflammatory of efficacy and AKC. So, from it was physiopathology. Why not a drug to try with this patient? And I tried in both patients with anacetyl, NAGA, and thialose. They all was already, before I start NAGA, on thialose. So, we saw slowly, baseline, 3 months, 6 months, lower clinical aspect with low functional plant. Good, best quality of life. Both told me you saw my life because really they were really a good impact on quality of life. So, in the two patients, all was clearly in clinical. The second one, it was really young. She was able to work again. So, in conclusion, complement seemed to be activated in this physiopathology of this. In these two cases, they suggest that NAGA could be useful in TSPK treatment, and I think clinically study will be useful, and exploring C3A, C5A in tears of this patient.
It's going to be
so possible. I was really thinking about the whole Bengaluru team, because you have a huge series of patients, and we can make a clinical study to evaluate after corticoid or not, if it can really in 3 months. In 1 month, you are really better, in 6 months, and of course, during these 6 months, no one recurrency. So, a new actor perhaps, and a new treatment if you are in impasse of therapeutic. Voilà. Thank you.
Thank you.
You have question?